Aloha, welcome back to General Pharmacology. Let's move the PowerPoint slides quickly. Let's see if we can go through this very quickly today. Last time I tried this, we ran out of time, so we're going to do this one more time and do it correctly. Think about this. Over 36 million people have died of AIDS, and around 40 million people are living with HIV, the virus that causes AIDS. The virus is HIV, human immunodeficiency virus. It causes a deficiency in our immune system, causing the patient infected with HIV not to be able to ward off infections. HIV is the virus that causes AIDS. HIV is called a retrovirus. Retro means reverse or backwards, and they're called retroviruses because they make genetic material in reverse of what we consider to be the positive direction. And so when you talk about messenger RNA or any kind of RNA or DNA for that matter, they'll talk about the strand being a positive. One of the strands is considered the positive strand. The other one is considered the negative strand. And so the retrovirus brings a positive strand with it and has to make the backward strand to make the DNA. And so that's where that word retrovirus comes from. It has an enzyme that makes genetic material in reverse of what we consider to be the positive direction. And so this important HIV protein called reverse transcriptase, it's called reverse transcriptase because it transcribes the genetic material in reverse of what we consider to be the forward direction. We will use reverse transcriptase inhibitors to fight these HIV infections. And you'll also hear that called antiretroviral therapy. HIV causes AIDS. So the virus is human immunodeficiency virus. AIDS is acquired immune deficiency syndrome. Again, acquired because we acquire it through a virus and causes deficiency to our immune system. All right, initially after HIV infection, someone can develop flu-like symptoms anywhere 2, 4, 6 weeks after becoming infected with HIV. And so this acute HIV infection, sometimes they'll call that primary HIV infection, sometimes they'll call it seroconversion syndrome, sometimes they'll call it HIV infection as we're moving in that direction. Something to be on the lookout for is the seroconversion rash. The signs and symptoms of seroconversion syndrome or primary HIV infection or acute HIV infection, they can include fever, headache, sore throat, swollen lymph glands, but something I want you to be aware of is rash. This is an acute HIV rash, a seroconversion rash, and it's pretty clearly demarcated. It's mostly on the chest, the trunk, and the arms when you look at pictures of this. So be on the lookout for this. This is a seroconversion rash, an acute HIV rash. Well, many times because of this early infection and these flu-like symptoms, they won't realize they've been infected with HIV. Maybe they'll think it's due to something else. Many initial HIV infections have absolutely no symptoms at all. Many acute HIV infections have no symptoms at all. And even if they don't have symptoms, they can still pass virus to others. We seem to be under some conception that we would have to be symptomatic with a virus to transmit it to somebody else, and that is not the case at all. We can be asymptomatic with a virus and still pass that virus to someone else, especially with HIV. We're going to see the body's not able to get rid of the virus. Once the virus enters the body, the immune system comes under attack. We can use medications to make the virus undetectable. We can test and say, wow, that virus is gone. But if we stop taking the medications, the virus comes right back because we're not able to get rid of the virus. We can take the medication until viral levels are undetectable, but the body is not able to get rid of the virus. Well, the virus is going to slowly multiply in T helper cells, those CD4 lymphocytes that we talked about last time. The CD4 lymphocytes help coordinate the entire immune system. And our big problem with HIV, its treatment and finding an immunization is this right here. When we give an immunization, we rely on cellular immunity and humoral immunity to respond to that immunization. And immunization requires normal immunity, a normally functioning immune system for the body to respond to that immunization properly. Well, HIV goes into the coordinator of the cellular immune system, the CD4 lymphocytes, and damages them and destroys them. And so this is main problem with treating HIV right here and coming up with an immunization. All right. If you read carefully about HIV, they'll divide the infection into various phases. I've seen 5 and 6 phases of HIV infection. I want you to know the 3 main phases of HIV infection, and then they have different names and different levels as we go along. Acute HIV infection is the earliest stage of HIV infection. It generally develops anywhere between 2, 4, 6 weeks after the infection with HIV. And during this time, people will have flu-like symptoms. We talked about that. Fever, headache, but especially rash. And we took a look at those acute HIV rashes. During this time, the HIV multiplies rapidly and spreads throughout the body. And during the acute HIV infection, the level of HIV in the blood is very high, even if they're not asymptomatic, even if they're not having symptoms from this acute HIV infection. Their viral load can be very high, and they can pass this on to others easily. A person may experience significant health benefits if they start antiretroviral therapy during this stage. And so something that we're seeing is if we use antiretroviral even before we think there's going to be an infection or immediately after a known risk, that we can definitely improve outcomes. And so something that we're learning is the sooner we can start antiretroviral therapy, the better. After the acute phase is the chronic phase, chronic HIV infection. The second stage of HIV infection is also called the asymptomatic HIV infection, also called clinical latency. You'll see the latent phase. And so during this stage, the HIV virus will continue to multiply in the body, but at much less levels than the acute phase. In people with chronic HIV infections, they might not have any HIV-related symptoms at all. And so that's why they call this latency kind of hidden, a hidden infection where they have HIV, but they have no symptoms whatsoever. However, they can still pass this virus on to other people. All right, without antiretroviral therapy, chronic HIV infection usually advances to AIDS. It usually takes about a decade for that to occur. That's normal. There are some people, the virus will advance to the AIDS stage very quickly. People who start taking antiretroviral therapy during the chronic part, they might stay in that stage for a very, very, very long time without progressing to AIDS. And it's still possible to transmit HIV to others during that clinically latent stage, the chronic stage. People who take antiretroviral therapy exactly as prescribed and maintain undetectable viral loads have effectively no risk of transmitting HIV to others, at least through sex. All right, AIDS is the most severe and final stage of HIV. Once the person starts to become symptomatic and meet certain criteria, then they meet the definition of AIDS. And because the HIV has severely damaged the immune system, the body cannot fight off certain things called opportunistic infections. And not only are there opportunistic infections, there's also opportunistic cancers and neoplasms growths. Neoplasm, neoplasm growth. Neoplasms can be growths that aren't necessarily cancer, but cancers are certainly neoplasms. And so not only do we see these opportunistic infections, we see opportunistic cancers, opportunistic neoplasms as well. This is the criteria I want you to remember for AIDS. They have to be HIV positive. We have to know that they have the HIV virus in them. And then they need to have a CD4 lymphocyte count of less than 200 If they have a CD4 lymphocyte count of less than 200, then that meets the definition of AIDS. Way back when, if they had a certain opportunistic infection and HIV positive, that would meet the definition of AIDS, and that was back when CD4 lymphocytes counts weren't so common. I'm sure there are places that can't do this, and so they rely on this definition down here, certain opportunistic infections and HIV positive. However, the definition that I want you to know, the definition that we work with, at least in a modern healthcare setting, is if they're HIV positive and they have a CD4 lymphocyte count of less than 200, that meets the definition of AIDS. All right, I promised to only divide this up into 3 categories. There is severe AIDS, and I wanted you to know that. That's when a CD4 lymphocyte count is less than 50. That is a very bad, very life-threatening situation, and we're going to be much more aggressive about how we treat certain things when we have severe AIDS. That's what I want you to know right there. In fact, we'll just keep it. I'll just repeat myself. Again, I want you to remember the definition of AIDS. To meet the criteria for AIDS, the patient must be HIV positive and have a CD4 lymphocyte count of less than 200, and that's cells per cubic millimeter, cells per femtoliter. All right, once a person is diagnosed with AIDS, they have a very high viral load. We'll measure that by looking for the messenger RNAs for HIV. We're going to talk about that at the end. And they can transmit HIV very easily to others. And without treatment, people with AIDS typically survive about 3 years. This is all according to the National Institute of Health and their AIDS info website. That's what I wanted to talk about first. All right, let's talk about opportunistic infections. I'm going to fix my slides as we go along. Hopefully I don't run out of time. All right, why do they call them opportunistic infections? Well, they take advantage of the opportunity offered by the weakened immune system, something that you're going to see when you read about and take care of patients with AIDS is that they'll have infections. They can have infections that the rest of us have, like the normal population can have, like tuberculosis. However, it's more common in the AIDS population, quite simply because of their weakened immune system. And so we can call them opportunistic infections in the AIDS population, but we wouldn't call it an opportunistic infection when we see it in the normal population. So keep that in mind. There are other infections that we do not see in the normal population that we'll only see in the HIV and AIDS population. So what are some of the symptoms of infection? Swollen lymph nodes. This is very common. One of the very first symptoms we'll see in somebody with AIDS is diffuse lymphadenopathy, swollen lymph nodes. Diarrhea, weight loss, and fever. These are nonspecific symptoms of infection, as are swollen lymph nodes. Cough and shortness of breath. This is typical of all sorts of different infections. Soaking night sweats. Cough, shortness of breath, soaking night sweats. That makes us think pneumonia. Shaking chills, fevers higher than 100 or 101 for several weeks. Again, dry cough, shortness of breath, that made the list twice. And so these sound like infections and are pneumonia. And pneumonia is very common when somebody develops AIDS. Diarrhea, persistent white spots in the mouth, headache, blurred vision, weight loss. Blurred and distorted vision is important because somebody with AIDS can get cytomegalovirus in their retina. We'll talk about that. And weight loss. I'll go through those again. All right, some opportunistic infections that we will see in our AIDS population. Tuberculosis, Mycobacterium avium complex, bacterial pneumonia, any kind of bacteria, septicemia. We'll see protozoa diseases as well, not necessarily bacterial infections. And the emergence of these protozoal diseases tells us that these are certainly opportunistic because we don't see these commonly in the general population. Pneumocystis jirovecii pneumonia is something that we only see in the HIV population or somebody who's severely immune compromised, we might see it. Back in the old days, it was called pneumocystis carinii pneumonia, PCP. Now it's called PJP. I have an x-ray of that. Here's our pneumocystis Hiroveci pneumonia, and we can see these little patchy filtrates. There's supposed to be a ground glass appearance. I guess those are the little ground glass appearances right there, the little white spots. If you look very carefully, you can see that dark spot. That's air. That's a little pneumatocele right there, and so we can see these little cavitations, these little cysts forming. And so anyway, that's an X-ray of pneumocystis Hiroveci pneumonia. That's an interesting thing to talk about if you have the X-ray in front of you. Toxoplasmosis, microsporidiasis, cryptosporidiasis, isosporiasis. These are very atypical protozoal diseases that we won't see unless they're opportunistic. Leishmaniasis, somewhere on my YouTube channel, I talk about leishmaniasis. This is one of the neglected infectious diseases. Very, very rare to see unless we're looking at someone with AIDS. We can see fungal infections as well. Candidiasis, that's very common in the normal population. However, it's also very common in the severely immune-compromised and AIDS population. Candidiasis, Cryptococcus, penicilliosis. Candidiasis, this is oral candidiasis. This is thrush. Little kids get thrush. Many times babies will get thrush for all sorts of reasons. When people use antibiotics, oral antibiotics, sometimes they'll develop thrush and we can give them an antifungal and it goes away. But in other situations, people can develop oral candidiasis, and it's very difficult to get rid of. Not only does the candida, the fungus, not only invade the mouth, but into the esophagus as well. This is an EGD, and a look into the food pipe going to the stomach, and we see this thrush even into the esophagus. This is extremely painful when this occurs, and so these are things that we'll see in AIDS. And that's one of the problems with the diseases, is it doesn't have this specific set of symptoms that we see. We just see what happens when somebody's immune system is severely weakened. And not only the infections, opportunistic infections can include bacteria and protozoa. We need to keep in track of the viral diseases as well. Keep in mind the viral diseases as well. Cytomegalovirus, herpes simplex, and herpes zoster virus. And when we have it in kids, it's chicken pox, and then it can reemerge as an adult, and then we'll call those shingles. It'll be a little bit different. They'll have similarities and differences, and I think I have some pictures of that. I wanted to show you cytomegalovirus. All right, if I took an ophthalmoscope and looked in a patient's eye, it should look just like this. This is the optic disc where the optic nerve is. That's our blind spot. There aren't any rods and cones for us to see, but that's where the blood vessels come out. And if we have them dilated properly and can see properly, we can see these little blood vessels pulsate. This is our fovea. This is where we focus. That little brown spot, that's supposed to be there. So anyway, that's all normal. If you ever see CMV retinitis, or pictures of it, or see it through an ophthalmoscope, the first time I saw it, I was a third-year medical student, and a very memorable thing to see the CMV retinitis. And so we can see these white and red patches developing on the retina, and this can cause blindness. And so this is something we definitely want to be on the lookout for with our HIV and AIDS patients, is any kind of visual changes they might be experiencing. We can also see herpes zoster, shingles. It's more difficult to see in people of color. Shingles matches a dermatome pattern where it will follow along the distribution of a nerve, and it very rarely crosses the midline. If it crosses the midline, it will only be like an inch or so. It will only follow one nerve pattern. We can see this here. There's the umbilicus, so that's the front. This is shingles wrapping around a nerve distribution. We can see here that we can see the little bulla, the little fluid-filled sacs, just like we see in chicken pox. And then these will scale and drain, and there's virus easily transmitted inside of those little vesicles. Shingles is not uncommon in the normal population. However, somebody who's immune compromised will see shingles far more frequently. And then we can see malignancies as well. Your body's immune system is responsible for fighting off these little cancers that develop. That's a normal part of your body's defenses. And cancers like lymphoma and squamous cell carcinoma are much more common in the AIDS population as opportunistic malignancies. One of the very first malignancies that we noticed with HIV, that's only associated with HIV, very rare to see Kaposi sarcoma with anything else. We always thought of this as a cancer until we realized that it's a neoplasm caused by yet another herpes virus, a type 8. It has this purplish appearance. If you're in the dental hygiene business, you want to be aware of these purple raised spots that people can have in their mouth. This is obviously very severe. Kaposi sarcoma coming from the roof of his mouth, and so we'll see Kaposi sarcoma in the mouth. Here it is on the ear, very clearly demarcated raised purple spots is how we define Kaposi sarcoma. In people of color, maybe the Kaposi's is not so purple, maybe it's a deeper bluish brown. So Kaposi sarcoma is something that we see in people with AIDS. All right, let's talk about the history of HIV. As recently as the 70s, no one was aware of the deadly illness. HIV probably transferred to humans somewhere in Africa around 1930 from monkeys, which have almost identical viruses to the HIV. The simian immune viruses are very similar to HIV. And so we think that there are tribes in Africa that hunt monkeys and eat them, and that's how we think that the HIV came to humans, is these a monkey immune deficiency virus probably moved to a human and then drifted into the form of HIV we have now. HIV enters North America somewhere around the 60s. Those numbers vary, maybe in the United States around the 70s. And this is, by the 1970s, African doctors are seeing a rise in opportunistic infections and wasting. Cancers and tuberculosis and infections cause wasting, where the person's nutrition is so poor that they waste away, they become emaciated. But in the West and in Europe, doctors are generally unaware of what's going on until about 1980. We started seeing AIDS in California and New York. These were the first cases, and the very first cases were among gay men and injecting drug users. And so anytime there's a new disease in the United States, if you watch the press very carefully, there's stigma involved. And so for AIDS to be first among gay men and injecting drug users, there was a big stigma with that, especially with the Reagan administration. And I think it made it hard to get the response, the appropriate response moving. Because of the stigma. And we see this today. Anytime we have a new disease to deal with, we'll see all sorts of acrimony until we finally get a handle on it and realize the correct direction to go. Well, by 1982, we start realizing that there are more people developing AIDS than just gay men and IV drug users. Hemophiliacs require blood transfusions. They have something wrong with their clotting, require blood transfusions. And so now we're starting to see in 1982 that people are developing AIDS after they've had a blood transfusion. And then AIDS is reported starts to develop in Europe as well. And so 1982 is where they came up with the name AIDS, Acquired Immune Deficiency Syndrome. It was 1984 that scientists finally realized that it's human immunodeficiency virus that's the cause of AIDS. Originally it's called human T-cell leukemia virus, and then they changed it to HIV. And so this human T-cell leukemia virus, the monkeys have the same, very, very, very same type of T-cell leukemia virus as well. And so We think that's where that came from. All right, well then by 1985 we were able to test the blood supply for HIV, and so it was 1985 that we stopped transmitting HIV virus through the nation's blood supply. AZT is the first antiretroviral drug that's approved for treating AIDS, and it shows early on promise, but something that we learn from AZT is that a single drug in the treatment of AIDS develops resistance. So it was 1996 when we started something called highly active antiretroviral therapy. This is a combination of at least 3 antiretroviral drugs taken together. Sometimes you'll hear this called a drug cocktail. And so it was 1996 when we started really developing an effective treatment. This was back when Magic Johnson was HIV positive. He was one of the first people to go on one of these drug cocktails, and he was one of the first people in the media to have completely suppressed the HIV virus load. And so that really helped move things in the correct direction, having a celebrity who was well respected treat the disease effectively. There's something called the Berlin patient. I'm going to let you Google that. You might have heard of this. In 2008, doctors in Berlin had an HIV positive patient who needed a bone transplant, I think for chronic myelogenous leukemia. And after that bone marrow transplant, they were able to rid his virus for quite some time. But that's a very interesting thing to read about. And bottom line is that, you know, bone marrow transplants are not going to be the treatment for HIV. This is just something that happened. We call it serendipitous, serendipitous, where it's not really a mistake, but we just kind of stumble into something and find out, wow, this is what happened. And so this person had a bone marrow transplant that essentially rid them of HIV for quite some time. The thing that I wanted you to know is this mutation in the CCR5 receptor. We're going to talk about the CCR5 receptor on the T lymphocyte. The CCR5 receptor is on the T lymphocyte, and this is how the HIV gets in. This is like the doorknob. The HIV, the attachment spike will attach that CCR5 and get into the cell. But people who have mutations, people who have different CCR5 receptors, they're able to resist HIV. And so one of the things we're researching is these people with these special CCR5 receptors on their lymphocytes that prevent them from prevent the HIV from entering their T cells. All right, let's talk about the parts and the life cycle of an HIV virus. All right, viruses cannot reproduce on their own. You can put a bacteria in a petri dish, and the bacteria has all of its mechanical machinery that it needs to sit and reproduce and reproduce. All it needs is the correct nutrients. Viruses cannot reproduce on their own. They require the cellular machinery of the host. So in order to make new copies of itself, viruses must infect the cells of a living organism and hijack their cellular machinery to reproduce. An HIV is about a 1/70th the diameter of a human CD4 cell, a T lymphocyte. And so you can see them under the microscope. If you can see a lymphocyte under the microscope and fill the field with it, then you can see the little HIV viruses as well. And so here's a cartoon of an infected CD4 lymphocyte, and you can see the relative size of a virus compared to a lymphocyte. This is an electron micrograph of HIV viruses budding off the infected CD4 lymphocyte. And so something interesting here is when they bud off, they take the phospholipid bilayer of the cell with them. That's why we talked about phospholipid bilayers in the second lecture. And so this is an important reason why HIV lives in bodily fluids. It has to live in warm bodily fluids because it can't survive without its phospholipid bilayer. So it has to be in a place where that phospholipid bilayer is well cared for, and that's in bodily fluids. All right, so there's the envelope. The envelope is made of the phospholipid bilayer, and that's what I want to show you right there. And then there are attachment spikes. When we talk about viruses, even if we talk about the COVID virus, there are attachment spikes that allow the virus to attach to the cell and get in. In this case, the envelope or the attachment spikes attach to the T lymphocyte to get into a cell. GP stands for glycoprotein, and as we go through this, you'll notice different glycoprotein names. I don't expect you to memorize these. I just want you to know that later on you might read about GP120 drugs, anti-GP120 drugs, anti-GP41 drugs, and these are drugs that just interfere with the function of the attachment spike. Maybe they'll be called fusion inhibitors. All right, so there's my envelope. Which is made up of the phospholipid bilayer and the attachment spikes. I'm going to tell you right now, when the virus goes into the cell, it's going to leave this part of the phospholipid behind on the cell membrane. Just like when we talked about cells invading, when a virus invades a cell, the cell will leave a surface antigen as part of its response. And so in the case of this virus, it leaves these attachment spikes on the phospholipid bilayer. All right, inside of that is the matrix. The matrix is made of P17 proteins. And then this is important, the viral core is also called a capsid. And so the viral core is where the genetic material is stored in the capsid. And in the capsid are viral RNA and 2 identical copies of that, and then 3 major types of enzymes, protease, integrase, and reverse transcriptase. And so this is going to be important because we're going to talk about protease inhibitors, we're going to talk about integrase inhibitors, we're going to talk about reverse transcriptase inhibitors. And so that's why we go over these enzymes. All right, so the virus brings with it a couple of copies of positive sense RNA, and the reverse transcriptase will make the negative sense RNA, and then together they'll make viral DNA, and that viral DNA will be integrated into the host cell. So again, integrase will integrate the viral DNA into the human DNA, and then the proteases cleave large proteins. Anything that can break a peptide bond we'll call a protease. We even talked about acetylcholinesterase being a protease when we had the second lecture. And so proteases will break apart the large proteins into their smaller pieces necessary for the assembly of new viruses. One of the new drugs that's coming out for COVID, one of the antiviral COVID drugs, works against the protease in the COVID as well. So we're going to use protease inhibitors to fight with COVID. Right now we're using protease inhibitors to fight with HIV. I wanted to show you this animation. This is an icosahedron. You might remember the icoso word meaning 20 when we talked about the icosanoids and prostaglandins. And sometimes you'll see this spelled with an I or an E or an EI. All right, and so viruses with this shape, what I wanted to show you is, look, all these are just little triangles. We've made this little spherical shape out of these little triangles. And something that viruses can do is if it makes their parts in such a way that they can spontaneously come together like little puzzle pieces. And so you might read about certain viruses having icosahedron shape. Not all do, however, that principle of taking the little triangles and just sticking them together into a structure, these triangles can spontaneously come together to form the structure, to me is just very fascinating. So I wanted you to be aware of that. That's what put the viruses together. The virus uses the cellular machinery to make all these little parts, and then once the parts are cleaned and ready, they'll just stick together and spontaneously form new viruses. All right, so here are, we went through the parts of the HIV virus. Here the HIV virus is attaching to the T helper lymphocyte. And right here on your notes, my notes should say this is a CCR5 receptor, and on one of my versions it does. This is the receptor on the T helper lymphocyte, the CD4 lymphocyte. And here are the attachment spikes on the virus attaching to that CCR5 receptor. And then notice when the HIV virus enters the lymphocyte, it leaves its envelope and the phospholipid bilayer and the attachment spikes on the center. All right, the matrix proteins and the capsid proteins will dissipate, and the genetic material and the enzymes are then released into the cell. So here we are in the pink cytoplasm of our T cell. And once that has occurred, the reverse transcriptase can then use the body's nucleotides to make the negative sense RNA, and together they make viral DNA. And so this is HIV virus DNA. It'll be called provirus if you read carefully. HIV and AIDS research, they'll call that DNA provirus. And that provirus will be transported into the cell's nucleus through this microtubule structure system in the cell, and that will be integrated into the viral DNA. Or I'm sorry, the viral DNA will be integrated into the human DNA, and integrase inhibitors interfere with that step, getting into the nucleus and being inserted into the normal DNA. Because look, you transcribe normal DNA and make, you transcribe normal DNA and make normal things, but once a virus is inserted into the normal DNA, then your body's normal machinery starts making the products that it needs to make new viruses. And all viruses work that way. They rely on the host and its cellular machinery to make the various parts that are needed to make new virus. All right, well, that HIV gene, that HIV provirus, it can lay dormant within a cell for a very, very, very long time. But when the cell becomes activated, it'll treat that HIV gene the same way it treats the human genes, and then we start making copies of this virus. Well, now the virus parts have been made and it's ready to exit, and when it buds off, notice it takes the phospholipid bilayer and the attachment spikes with it. And so not only are we going to use medications that interfere with these enzymes, we're also going to use medications that interfere with this virus's, not only its ability to attach, but its ability to exit as well. All right, so once the infected cell has produced all the components, we've talked about the components begin to reassemble, form new viruses. The viruses exit by budding, and again, this is what we see on this electron micrograph. We see all these viruses, these HIV viruses emerging, and we can see this matrix on the inside, and then once it buds loose, it takes the phospholipid bilayer and attachment spikes with it. All right, so it's the biologic properties of the envelope, that phospholipid bilayer, that HIV must be transmitted by bodily fluids, mainly blood, because that is the place where the phospholipid is able to survive. And so that's why HIV is transmitted through bodily fluids. Needle sharing amongst IV drug users, blood transfusions from the 70s up until 1985, and sexual intercourse. These are main forms of transmission of HIV. Vertical transmission is when the mother transmits something to the baby, either intrauterine or during the delivery. That's vertical transmission. Breastfeeding can also pass HIV from the mother to the fetus as well. So something you want to do as a clinician is be on the lookout for high-risk behaviors. You have to talk to people and listen to them and gain their trust to know if they use injected drugs, share needles, or any of that paraphernalia, because these are certainly high-risk behaviors for contracting HIV. Unprotected sex in any manner described here is a high-risk indicator for contracting HIV. as well as having or being treated for sexually transmitted diseases. And so that's why if you check out the Maui AIDS Foundation or any AIDS foundation that treats HIV and AIDS population, they'll do a lot of testing for sexually transmitted diseases because the presence of sexually transmitted diseases is a high risk indicator for the potential for HIV. All right, these slides here are a little old, or very old, but the numbers haven't changed too much. Males outnumber females in the number of adults living with HIV. Something I will say is the numbers have kind of leveled off over the years. Certainly in the early 2000s, during this point, the numbers were going up, but the numbers aren't too much different, and neither are the increases. But things have leveled off a little bit in recent years. Blacks outnumber whites, outnumber Hispanics in the number of people living with either HIV or AIDS, as well as Pacific Islanders and American Indians, Alaska Natives. This was on a high rate of increase around that time. Things have leveled off, but we're certainly not out of the woods. HIV is by no means cured. I wanted to just show you these slides. These haven't changed too much over the years. This is a comparison of how females, contract HIV compared to males. And so I'll draw your attention over here. The most likely way for a female to contract HIV is through high-risk heterosexual contact. Her chances of getting it through IV drug use, or 19% of women that they interviewed in the study, they got their HIV from IV drug use. 80% of them contracted HIV through high-risk heterosexual contact. Males, on the other hand, male-to-male sexual contact, homosexual contact accounts for nearly 70% of HIV and AIDS cases. High-risk heterosexual contact for men, only about 15% of men contract HIV through, only 15% of men who have HIV contracted that through heterosexual contact, and injecting drug use, not too much different than the women. So I wanted you to see women, 80% through high-risk heterosexual contact. Men, their highest risk is male-to-male sexual contact. All right, we'll talk about the anti-HIV medications. We'll also see those called antiretroviral therapy, ART. The anti-HIV medications are used to control the reproduction of virus, slow the progression of the virus. But again, these medications cannot make the virus go away. We can suppress the virus to undetectable levels, but we cannot rid the body of the virus. So although they can suppress HIV to undetectable levels, they do not rid the body entirely of HIV, because if the person stops taking their drug cocktails, the HIV will come back, and not only will it come back, it'll be resistant to those medications, more likely to be resistant to those medications. And so taking the antiretroviral therapy is something that occurs throughout the lifetime of the HIV AIDS patient. There have been no immunizations that have been found to be effective. The messenger RNA technology that we are using to have an immunizations against COVID has led us into using a messenger RNA virus against HIV. I think Moderna right now, the people who spearheaded messenger RNA technology as an immunization, they're working on an immunization for HIV right now, and so it'll be interesting to see where that goes. All right, there used to be 5 and now there's 6, and really there's more than that if we have time to look at the website. There's all sorts of major classes of antiretrovirals. Like anything else, we have to narrow it down to something simple. The nucleoside reverse transcriptase inhibitors came first. AZT was a nucleoside reverse transcriptase inhibitor. Nucleoside reverse transcriptase inhibitors are analogs of the nucleosides and the nucleotides that we talked about during the second lecture. And so during the second lecture, if you remember the shape of a nucleotide, Well, we can change the nucleotide in such a way that it won't form a chain. And so when we take a normal nucleotide and we either change the phosphate group or the 3' end, if we change one of those ends, we can make the chain stop. And so that's why these will be called chain breakers. They're analogs of nucleosides. And they just break the chain. They don't really interfere with reverse transcriptase. They just get incorporated and break the chain. Remdesivir, which is what we're using for COVID, is a type of nucleoside chain breaker. And so we'll see that strategy with other viruses as well. All right, so the NRTIs are the nucleoside analog reverse transcriptase inhibitors. You'll hear them called nukes. You'll hear them called chain breakers. All right, well, non-nucleoside reverse transcriptase inhibitors, they're not nucleoside analogs. What they are is they're drugs that actually attach to the reverse transcriptase inhibitor, prevent it from functioning properly. So even though these two sound alike and it gets confusing, these two drugs are very different from each other. They share a very long part of their name except the word non. All right. And so the nucleoside reverse transcriptase inhibitors are chain breakers. The non-nucleoside reverse transcriptase inhibitors actually interfere with reverse transcriptase itself. We'll talk about protease inhibitors, fusion inhibitors, and then there's different classes of fusion inhibitors. There's ones that interfere with entry, and then you'll see drugs that interfere with exit and budding as well. Integrase inhibitors, and now we have more specific CCR5 receptor inhibitors, and I have a larger list than this if we can get to that website if I make it on time. All right, so certain fusion inhibitors will interfere with the GP120 proteins or the GP41 proteins so that the attachment cannot occur. Let's see if I have that there. Yeah, and here's my CCR5 receptor on this T helper lymphocyte. We can use medications that interfere with that receptor being able to accept the HIV virus or attach the HIV virus. All right, remember reverse transcriptase, integrase, and protease. We use protease inhibitors, integrase inhibitors, reverse transcriptase inhibitors, two types of reverse transcriptase inhibitors, nucleoside and non-nucleoside. This is what I want you to know. We'll go through a lot of medications for HIV, but I want you to know about highly active antiretroviral therapy. Remember, ART is antiretroviral therapy, and HAART, highly active antiretroviral therapy, is the proper combination of drugs to treat HIV. And so HART is 2 nucleoside reverse transcriptase inhibitors, 2 nucleoside analog reverse transcriptase inhibitors in combination with a protease inhibitor. And then we'll talk about ritonavir boosting in just a second. And this is what's most common in HART. We can use a non-nucleoside reverse transcriptase inhibitor instead of the protease inhibitor to have highly active antiretroviral therapy. And so this is what I want you to know right here. 2 nucleoside reverse transcriptase inhibitors and a protease inhibitor, or instead of a protease inhibitor, we can have a non-nucleoside reverse transcriptase inhibitor. And so this is what you're going to see the drug combinations made up. We can look at each of these as individual drugs. However, there are many manufacturers that will put 2 nucleoside reverse transcriptase inhibitors in one pill. Maybe all 3 of the, you'll see medications where all 3 of the drugs are part of HART. Oh, and there we are. Yeah, I took a bunch out then. Let's see here. Oh, can I click on it? Let's see if it works. Oh, there we go. This is the website I've been using for much of the updates for this lecture. hivinfo.nih.gov. You can't see that, but we'll have that at the end of the slides. This is excellent website, and something that I wanted you to see from all this are the lists of medications that we have. Rather than me keep up with my slides, I'll just click on the website. All right, so we talked about the nucleoside reverse transcriptase inhibitors. They block reverse transcriptase. They actually are chain breakers. They interfere with reverse transcriptase being able to reproduce. And then you can see these names. Oops, I guess you can't, can you? There you go. Ziagen, emtricitabine, Emtriva, Epivir, Viriad. You guys can take a look at those words. Retrovir is AZT, zidovudine, March of 1987. All right. The non-nucleoside reverse transcriptase, doravirine, efavirenz, etravirine, and nevirapine, pilfeltro, sestiva, Intilence, viramune, viramune XR. These are all non-nucleoside reverse transcriptase inhibitors. The first one from 1996. Rilpiravine is also a non-nucleoside reverse transcriptase inhibitor. Protease inhibitor, atazanavir, Reataz, darunavir, Prazista, fosemprenavir is Lexiva. Ritonavir is very interesting, and my ritonavir boosting slide disappeared. You'll see something called ritonavir boosting. Here, let's. And now they're called, according to this, they're calling them pharmacologic enhancers. All right, so ritonavir, although it is a protease inhibitor, what it does is it blocks the body from breaking down other protease inhibitors. And so that's what you'll see with ritonavir. If you see ritonavir boosting, what ritonavir boosting means is ritonavir is generally given in combination with another protease inhibitor to prevent that other protease inhibitor from being broken down. We talked about this strategy before when we talked about antibiotics. We'd use this antibiotic to kill the bacteria, and we'd use this chemical to prevent the bacteria from breaking down the antibiotic. When we talked about L-DOPA, we used carbidopa to prevent the body from transforming the L-DOPA. And that's all called pharmacokinetic enhancing. And so the same thing with ritonavir. Ritonavir interferes with the body's ability to break down other protease inhibitors. All right. What else is on our list? Sequinavir, Inverase, Topranavir, Aptivus. All right. And then we talked about these fusion inhibitors. And here, the fusion inhibitors block HIV from entering the CD4 lymphocyte. We can do that CCR5 antagonism, drugs that block that CCR5 receptor. So fusion inhibitors in fuviritide, Fusion. And then you can see how these are abbreviated, T20. Maraviroc, Cellzentry, that's a nice marketing name, as a CCR5 antagonist. The integrase inhibitors were more recent, yeah. This was the first one that I remember, Icentris, Raltegravir, but there are other integrase inhibitors as well. Cabotegravir, Vocabria, Dolutegravir is Tivicay, and Icentris, again, is the first integrase inhibitor. I think of these as fusion inhibitors. We'll call them attachment inhibitors as in this setting, but I see these as fusion. I call these fusion inhibitors as well. And notice, what does it do? It interferes with the GP120 protein. You'll see other fusion inhibitors that interfere with GP41. Fostemsavir, Rucobia, is a GP120 inhibitor. Post attachment inhibitors, these are newer. Trogarzo blocks the CCR5 receptor. Again, blocks the CD4 receptor that the HIV needs to enter the cell. And then another pharmacokinetic enhancer besides ritonavir is cobicistat, Tybost, and it's going to interfere with the body's, it's going to increase the effectiveness of other HIV medications as well. So you might see this boosting as well. You'll see ritonavir boosting, cobicistat boosting as well. And then all sorts of combinations. So I have this link on the slides. I'll make sure you guys get that, and you can keep up with what's up to date with the medication list. I think I'm going to start getting, other than put the medication lists in my slides, I think I'm going to start doing medication lists like this. So, all right, if we close that, hopefully we'll go back over to my PowerPoint slides. And just because I know you have a lot of this information is coming right here, hivinfo.nih.gov. All right, so that's where we were. Oh, it just blew up. There we go. All right, back to our regularly scheduled program. All right, something that we're not going to cover today, but something I wanted you to be aware of. This is your homework, to Google these things. Pre-exposure prophylaxis and then post-exposure prophylaxis. Prophylaxis means prevention. If we give a medication to prevent something from happening, that's called prophylaxis. Like if you go to another country, you'll take drugs to prevent malaria or prevent certain types of infections. That's called prophylaxis. Pre-exposure prophylaxis is for people if we know that they might be exposed to a high-risk event for whatever reason. We might start them on antiretroviral therapy before the event. Post-exposure prophylaxis started in the last decade or so, and the more we use this, the more we see how effective it is. If somebody has a high-risk injury or encounter and has a high risk of contracting HIV from that encounter or injury, we can start antiretroviral therapy on them immediately, and that's called post-exposure prophylaxis. So if you're a healthcare worker and you are concerned, if you're a healthcare worker, you should be aware of what post-exposure prophylaxis is for a healthcare worker, because the people who are supposed to be in charge of keeping track of that, sometimes that information changes, and so you as a healthcare worker want to know what to do if you get a needle stick from someone that either you don't know or know has HIV. All right, well, how do we decide which medication to use? It has to do with the genotype of the virus. Certain HIV viruses have developed resistance to certain drugs. Toxicity, some drugs in combination are more toxic. Compliance, some drugs are going to increase viral resistance if the person's compliance is not absolutely perfect. We see this is common with the treatment of diabetes. We're not going to put an insulin pump. We're not going to put a complex insulin pump that requires a cell phone and very careful control to somebody who's not going to be compliant. They're not going to take care of it. They're not going to do what they're supposed to do. There's no reason to use an insulin pump with them. If anything, we can make things worse. Same thing with the HIV drugs. There are drugs that really they have to have absolute compliance to use those medications. Otherwise, those drugs have a very high risk of increasing viral resistance. And so how compliant the person is a deciding factor in the treatments that we choose, not only for HIV, but other things as well. Previous failures. This is something interesting thing about HIV is that if somebody's been on an antiretroviral drug and they've had a failure, we're not going to use that drug again. And so if they've had previous failures with certain medications, then those medications we're not going to try and use again. If the woman is pregnant, the drug cocktails that we'll use, the antiretroviral therapy drugs that we'll use for her will be a little bit different. Maybe we'll dose them differently, maybe we'll have them in different combinations. All right. There is no monotherapy for HIV. Monotherapy has led to resistance and resistant variants of the virus, and certainly treatment failures. So drug combinations right now are the only way to go. All right, well, drug therapy can be more than just antiretroviral therapy. Drug therapy for somebody with AIDS includes prophylaxis against many of the infections that we talked about. And many times this is determined by the CD4 lymphocyte count. If their CD4 lymphocyte count starts to get really low, then we'll be more aggressive about using prophylaxis against opportunistic infections. Lipodystrophy syndrome develops in many people due to the use of antiretrovirals. Lipofat dystrophy, something wrong with, trophy is growth, and so people with lipodystrophy syndrome, they'll have abnormalities in the way their fat is stored, and we can see changes in the fat pads of the face. So we'll see facial wasting in lipodystrophy syndrome due to the use of antiretroviral therapy. Tesamorelin, Agrifta, was approved by the USDA to treat this. All right, let's talk about the lab tests for HIV. Obviously, an antibody test will test the body for certain antibodies. We'll test the person for certain antibodies that they'll make against HIV. And so that antibody test is something that we require to diagnose them with HIV. However, we can measure the RNA we can measure the HIV RNAs, and those are called viral load. And so when we have high levels of human immunodeficiency virus RNA in our plasma, then that tells us that we are loaded with virus. And so the plasma HIV RNA, you can see these HIV RNA tests are called the viral load. I will tell you right now that during the acute phase of HIV, plasma HIV RNA levels are the first to go up. Obviously, the lymphocyte count, the T helper lymphocyte count, the CD4 count, you'll hear that called the absolute CD4 count. That tells us the health of the immune system and whether they meet the criteria for AIDS. And then all the tests that we do on the virus to see what type of virus that is, or what the type of HIV virus, the type of variant the HIV virus is. All right, what we're trying to show you here is the RNA levels of the virus go up before the antibody levels go up. And so what we're showing you right here, okay, exposure occurs on day 0, all right? And so this is the course of a primary HIV infection or an acute HIV infection. This measures the antibodies over here. This is HIV RNA. All right, and this first curve right here is that HIV RNA. Notice by about day 18 right here, my HIV RNA levels are really high, and yet my antibody levels haven't even started to go up. So in the first couple of weeks, the first test that's going to be positive in somebody who has acute HIV, primary HIV, is going to be that RNA level. And so if we think somebody's been exposed and we're waiting to see if they seroconvert, the first test that we want to do is HIV RNA, because that will turn positive first. So in the first days of acute HIV infection, HIV RNA is the earliest lab test to show HIV infection. So I've heard healthcare workers talk about getting exposed to HIV, or maybe they got a dirty needle stick, and now they're getting tested for HIV to see if that test becomes positive, and those tests are antibody tests. All right, so the test that we want to use while we're waiting to see is the RNA, because that'll turn positive first. And then, of course, we can use post-exposure prophylaxis, antiretroviral therapy anyway, and we've shown that that's generally safe and very effective. All right, well, something that we do with the general public, test for sexually transmitted diseases. If you have a population and they have a high risk of contracting sexually transmitted diseases, then they have a high risk of having HIV. And so that's why we'll do tests for sexually transmitted diseases like syphilis, hepatitis B and C. I don't think A needs to be on there. Chlamydia, gonorrhea, pap smears. Cervical cancers are very common in women who do not get pap smears. And then after the development of the Papa Nicolau stain, the pap smear, we're able to essentially get rid of cervical cancer. So I think I will tell you that a woman who has AIDS, that cervical cancer becomes an opportunistic neoplasm. And so it's essential that women who have HIV get pap smears to determine if cervical cancer is developing. But don't take my word for any of this. Go to this website right here, hivinfo.nih.gov. I like the National Institute of Health for a lot of information. And so check out this website, hivinfo.nih.gov. Avert.org is another excellent, avert.org. Avert is an excellent excellent place to get international information. But I was really happy with the information that I got from this website. So I want you guys to check this out. Be sure and look at pre-exposure prophylaxis and post-exposure prophylaxis. Make sure you have a good handle on those things, especially before you go out into the healthcare setting in the general public. Well, that's more than enough for one day. When we come back, we'll be in section 5. We're going to start talking about cancer and chemotherapy, and we're going to talk about infectious disease agents. Antimicrobial agents and things that cause infectious disease. Something that I wanted to point out at this point was that in the treatment of HIV, we did things to interfere with with the reproduction of its genetic material. We interfered with reverse transcriptase, we used chain breakers, and we're going to see this again as we go through cancer and chemotherapy and when we go through antimicrobial agents, that we're going to do things to interfere with DNA and RNA replication. We're going to do things that interfere with nucleic acid reproduction. That's going to be a strategy. There's going to be other things that we do, but the strategy of interfering with DNA and RNA replication, we started talking about that with HIV and AIDS, and we're going to talk a lot about that when we talk about cancer chemotherapy and antimicrobial agents. So until then, aloha.